Welcome to the UC San Diego School of Medicine Ultrasound Series. My name is Virag Shah, and I, along with my co-instructor, Dr. Anthony Medak, will be discussing beginner-level musculoskeletal ultrasound in this module. We will begin this lecture with a brief overview of the uses of musculoskeletal ultrasound. We will then demonstrate the sonographic appearance of common tissues in the body, such as bone and tendons, and then discuss the physics concept of anisotropy. Next, we will go over the learning objectives for your hands-on group sessions, which include various joints and structures in the upper and lower extremities. Finally, we will discuss examples of musculoskeletal pathology before concluding our session. While our module will primarily focus on the anatomic appearance of various structures, here we briefly discuss the various clinical applications of musculoskeletal ultrasound. Diagnostic uses include evaluation for bony fractures, joint dislocations, effusions, and bursitis. The video clip on the top demonstrates how even a tiny disruption of the bony cortex can be detected with ultrasound in certain situations, such as the sternal fracture, which could otherwise be missed on a plain radiograph. Additionally, tendon and ligament injuries can be evaluated with the use of bedside ultrasound. Furthermore, ultrasound has always been useful in guiding various procedures, and this is also true in the musculoskeletal setting. It may be utilized in hematoma blocks for anesthesia of a fracture, or for joint fluid aspiration, or for confirmation of a reduced fracture or dislocation. Additionally, as demonstrated in the video clip, ultrasound may also be used to visualize nerves to increase the success rate of nerve blocks. Bone appears bright on ultrasound because of its densely calcified cortex, which reflects virtually all ultrasound waves back to the transducer. Typically, only the cortex or surface is visualized as illustrated in this clip of the distal femur. Note that effusions and acute hematomas appear as black anechoic collections around the joint or fracture. The image on the right demonstrates a knee effusion viewed in the long axis. Soft tissue contains a variety of structures that are easily identified on ultrasound. Examples include subcutaneous fat, muscles, tendons, nerves, vasculature, and connective tissue planes. This video clip of the forearm demonstrates several of the structures that may be contained within soft tissue. Subcutaneous fat is relatively hypoechoic, with thin septations of connective tissue. Muscle, on the other hand, when viewed longitudinally, appears as layers of irregularly striated hypoechoic tissue contained within thin hyperechoic lines of fascia. In the transverse view, the muscle striations appear dotted and punctate. Fascial lines separate muscle compartments. Bursa refer to a closed sac or envelope lined with a membrane containing lubricating fluid. These are found in areas of high friction throughout the body, oftentimes between bone and tendons. Under normal circumstances, the bursa are hardly visible on bedside ultrasound. However, they may be more easily seen if inflamed or infected. Hyaline cartilage appears as a thin hypoechoic or sometimes anechoic band, which is delineated by hyperechoic margins. Here is an example of hyaline cartilage at the knee joint in a pediatric patient. Tendons normally appear hyperechoic and fibrillar on ultrasound. Like muscle, they have a striated appearance. However, tendons appear much more densely striated than a muscle would, as illustrated by the patellar tendon in this diagram. A normal tendon may demonstrate the phenomenon of anisotropy, which we will further discuss in a minute. Here is a video clip of the patellar tendon from the prior slide. Note again that the tendon has fibrillar appearance and appears to be striated in a much more dense fashion compared to muscle. Anisotropy refers to a change in the grayscale echogenicity of a structure when it is evaluated at different angles of inclination. In other words, a structure such as a tendon may appear hyperechoic or hypoechoic when the scanning angle is altered. The maximum return echo occurs when the ultrasound beam is perpendicular to the tendon. Decreasing the incidentating angle on a normal tendon will cause it to change from brightly hyperechoic to darkly hypoechoic. This phenomenon is also observed with ligaments and nerves. Because structures such as nerves and tendons do not run a straight course for a significant distance, the sonographer must continually change the transducer's angle to overcome this phenomenon and avoid misinterpreting a hypoechoic area as a lesion such as a tear. A nerve bundle consists of surrounding epineurium, which contains axonal bundles within. The axonal bundles are referred to as fascicles, and they are separated by connective tissue. Axons are composed of mostly water and therefore can appear as black dots in the transverse axis. The remainder of the nerve bundle typically has a more hyperechoic appearance when imaged properly at a perpendicular angle. Overall, nerves run along fascial planes and are often paired with vascular structures. As mentioned on the prior slide, due to the presence of axons and connective tissue, nerves imaged in the transverse axis tend to have a speckled or honeycomb appearance as illustrated. For most musculoskeletal exams, the high-frequency linear transducer will be used during scanning. We will next discuss the appearance of nerves in the forearm. We will begin with the radial nerve, which can be visualized in the forearm alongside the radial artery. Note that the left arm of the patient is being scanned in this example. By orienting your probe with the normal convention, that is, keeping the probe marker to the patient's right, this will result in an image as shown on the right panel. Notice that the radial nerve is located to the radial aspect of the corresponding artery. Here, the radial artery is again demonstrated in the same patient with the use of Doppler ultrasound. Notice the corresponding radial nerve. The ulnar nerve can similarly be visualized on the volar forearm as well. Once again, the example demonstrates the left arm being scanned by the examiner. Again, assuming that the probe orientation is correct with the probe marker to the patient's right, the ulnar nerve will appear adjacent to the ulnar artery as illustrated. Notice that the ulnar nerve is located to the ulnar aspect of the corresponding artery. And once more, here is the same patient being scanned in Doppler mode. Notice again that the ulnar artery demonstrates flow and the ulnar nerve neighbors the vessel. The median nerve, while not associated with any artery or vein, is still fairly easy to identify in the mid-forearm. As demonstrated in the video, the probe is placed near the mid-wrist and then slid proximally up the forearm. The nerve should be visualized in the fascial plane between muscles in the anterior compartment. Here is another example without any labels. Are you able to identify the median nerve? The nerve is highlighted here. Next, we will use a water bath to visualize the digits of the hand. Recall from our introductory session that the ultrasound beam created by the transducer has a focus, or a region where the beam is most concentrating with sound wave energy. By placing your structure of interest at the beam focus, the image will have optimal lateral resolution. In other words, you will have a better image when trying to place the tissue or organ you wish to evaluate in the focal area as shown in the diagram. As one can imagine, however, a sonographer that is trying to place a structure in the middle of the screen may have some difficulty accomplishing this if the structure is very superficial. In some settings, very high-frequency probes with small footprints are available as illustrated for imaging smaller structures such as the fingers. An alternate method to visualizing superficial structures such as the fingers is using a water bath. As shown in the video, the patient's hand may be placed in a shallow water bath which is then used as a scanning medium. This medium obviates the need for gel, and the probe footprint itself can be placed underwater. Additionally, this method may prove to be more comfortable in patients whom placing pressure on soft tissues may be painful, such as those with a finger fracture or abscess. While the probe footprint can be brought under the water's surface, please ensure to avoid bringing the proximal portion of the probe or wires into the water. Shown here is an example of the distal thumb, which is evaluated from the dorsal aspect. Notice that the water in the water bath is nearly black, however it does not appear completely anechoic. This is a result of air bubbles within the water, resulting in a small amount of signal being reflected back to the ultrasound probe. Overall, various structures can be visualized from the dorsum of the digit, including the interphalangeal joint space. In this video, the thumb is being flexed and extended. Extension of the distal phalanx is primarily performed by the extensor pollicis longus tendon, which inserts into the base of the distal phalanx. Here is an example of a digit, the index finger in this case, being evaluated from the volar aspect. Notice that the distal portion of the digit is scanned and the DIP joint is easily identifiable. Here is the same digit now being flexed at the DIP joint. Flexion of the distal phalanx is primarily performed by the flexor digitorum profundus tendon, which can actually be visualized in this video. Here is another look at the flexor digitorum profundus tendon. Next, Dr. Medak will discuss ultrasonography of the anterior knee, followed by some examples of pathology.
And now, let's focus our attention to the knee as we continue our discussion of musculoskeletal ultrasound. Regarding the knee, let's first talk a little bit about the relevant anatomy. As you recall, the knee is a synovial joint of hyaline cartilage, and it involves the articulation of the femur, tibia, as well as the patella, as you can see demonstrated in the animation below. The knee is stabilized by a number of ligaments, many of which are quite well visualized with ultrasound, and we'll get into that in just a few moments. Here's some additional illustrations with some relevant anatomy that I'd like you to pay particular attention to. Today we're going to be focusing our attention on the anterior aspect of the knee as we perform our ultrasound exam. As part of that exam, we're going to evaluate the quadriceps tendon here, the patella, the patellar tendon, as well as the suprapatellar recess and infrapatellar recess. I'd also like to take this moment for you to pay particular attention to the bursa of the anterior aspect of the knee, which you can see here and here. Now these bursa in the normal condition are not well visualized on ultrasound because they're rather small, and unless they are filled with fluid, are not easily discerned when we're doing our ultrasound exam. These bursa play an important role in the function of the knee as they serve a purpose to decrease friction during normal flexion and extension of the joint. You may ask, why would we want to perform a knee exam with ultrasound? There are many reasons. The list here is by no means comprehensive, but is just certainly an overall look at some of the reasons you might want to perform ultrasound of this particular joint. One that easily comes to mind is the assessment of joint effusions. In addition, as you're about to see in a few of the slides that come ahead, we can get excellent visualization of both the quadriceps and the patellar tendon, and so pathology in these areas be quite easily discerned with ultrasound exams. Although we won't be paying much attention today to the evaluation of the posterior aspect of the knee, it's important to realize that as part of a comprehensive knee exam, which we will discuss in just a moment, one would examine the posterior aspect of the knee, including evaluation for a Baker cyst. A Baker cyst is a fluid-filled structure that results from the gastrocnemius and the semimembranosus bursa. When this bursa is overly distended with fluid, it manifests as swelling and tenderness in the posterior aspect of the knee. Because it's fluid-filled, and because the popliteal fossa is readily visualized with ultrasound, this is a great modality to evaluate for this particular pathology. In addition, ultrasound of the knee lends itself for procedural guidance to aspirate fluid, inject steroids, and things of that sort. Now, One thing to keep in mind is that the knee ultrasound exam is ideal in many respects. However, there are shortcomings. It's important to realize that ultrasound of the knee is not indicated for definitive assessment of the cruciate ligaments. And I'd like you to ponder that for just a moment as to why. If you think about it as you consider this question, remember where the cruciate ligaments are located and what the adjacent structures are to them. The cruciate ligaments are located deep within the internal aspects of the knee and are surrounded, of course, by the bony cortex of the articular surfaces of the distal femur and the proximal tibia. As a result, they're not well visualized with ultrasound, and one would need to use another imaging modality, for example MRI, for definitive assessment of these structures. One other unique aspect of musculoskeletal ultrasound that can be seen as an example in the knee is the opportunity to perform dynamic imaging. And by that we mean trying to do real-time ultrasound while the patient ranges the affected joint. So if, for example, a patient has pain when they perform a particular movement, you can have them perform that movement, as in this loop that you see here, the patient is flexing and extending their knee, and we're able to actually demonstrate and perhaps reproduce their symptoms and get a better idea of what may be causing their symptoms. This particular technique, although it sounds simple, can often allow us to identify pathology that might otherwise be easily missed. Now, when we talk about the knee exam with ultrasound, one must consider there are circumstances that would dictate that sometimes a comprehensive exam is indicated as opposed to a more focused exam, depending on the clinical scenario. A comprehensive exam of the knee would involve ultrasound of the 4 quadrants of the knee: the anterior quadrant of the knee, the medial, the lateral, and finally the posterior quadrant of the knee. Today we're going to be focusing our attention on this anterior quadrant, and thus we will be doing the following. We will assess the quadriceps and patellar tendons. We will evaluate the suprapatellar as well as the infrapatellar recess, the anterior bursa of the knee, as well as the femoral trochlear view. In terms of the equipment necessary, as has been the case with the other aspects of the musculoskeletal exam that we talked about today, we will continue to want to use the high-frequency linear transducer for the reasons discussed previously, primarily because its high frequency lends itself to better anatomic detail for the superficial structures of interest with this particular exam. In terms of patient position, you would like to have the patient placed supine with their knee flexed at approximately 20 to 30 degrees. This can easily be accomplished by placing a towel or perhaps a pillow behind the knee such that you can get the correct degree of flexion. This position is important for many reasons, not the least of which is that when the knee is flexed to this extent, it will decrease the amount of anisotropy that is often encountered with the quadriceps and patellar tendons when the knee is in full extension. The first step in the anterior knee exam will involve visualizing the quadriceps tendon in a long as well as short axis. This is a long axis view of the quadriceps tendon. To obtain this view, we place the ultrasound probe just superior to the patella in a longitudinal axis relative to the knee. To give you your landmarks, here is the patella along the inferior aspect of the image. Here is the cortex of the femur. And here we have outlined the quadriceps tendon. Again, for orientation, note the orientation marker is to the left of the screen, so by definition, this should be cephalad. So this is superior, this is inferior. Here we have our quadriceps tendon, and note particular attention as it inserts onto the patella. This area is the suprapatellar fat pad, which is also important, and we'll discuss this again in just a few moments. Here's a video clip showing that same anatomy. Patella, femur, quadriceps tendon, suprapatellar fat pad. As with everything else we've discussed with ultrasound today, we will want to obtain images in both a short and long axis. This is a short axis view of the quadriceps tendon, obtained by placing the probe in 90 degrees orientation from the previous position when we had it in long axis. Simply rotate the probe 90 degrees with the marker dot oriented to the patient's right. And in doing so, you'll have this image here. This is an outline of the distal aspect of the rectus femoris muscle, which, as it terminates, will become a large portion of the quadriceps tendon. Here's a video clip demonstrating the distal aspect of the rectus femoris muscle, and as we extend inferiorly towards the patella, it becomes the quadriceps tendon. Now, let's pay particular attention to the suprapatellar recess. This is just deep to the quadriceps tendon, and it's very important to pay particular attention to this area because this is where we can detect joint effusions or hemarthroses, for example. So, for orientation again, here's patella, here's femur, here is our quadriceps tendon, and this is the area of the suprapatellar recess. This area is the suprapatellar fat pad. This area here is called the prefemoral fat pad. When there is fluid in the joint, it'll often tract and dissect between these two, such that you'll have a separation of the suprapatellar fat pad and the prefemoral fat pad. Now, with that in mind, what do you think of this particular image? Again, here's patella, here's quadriceps tendon, here is suprapatellar fat pad, here is some of the prefemoral fat pad, and clearly you can see a very well demarcated anechoic fluid collection. This is consistent with a joint effusion. Now, let's move along inferiorly and evaluate the patellar tendon and the associated bursa. Again, here the technique is going to be very similar to what we did for the quadriceps tendon. It's going to involve both a long axis view and a short axis view. In addition to looking at the tendon itself, we're going to want to pay particular attention to the infrapatellar fat pad, which is also referred to as the fat pad of Hoffa. In general, the prepatellar bursa located in this area are not normally visible unless there is an infection or distension of the bursa for some other reason. Here is a long axis view of the patellar tendon. This is the patella. This is the superior pole of the patella. This is the inferior pole of the patella. And again, I say that simply because our orientation marker is placed this way, and thus we know this is the cephalad direction. Here is a patellar tendon, and you can see here where it inserts onto the patella itself. And this is Hoffa's fat pad. Here's a video clip demonstrating that same anatomy. Here we can see the tibial tuberosity where the patellar tendon will actually insert. Patella, patellar tendon, and Hoffa's fat pad. As with the quadriceps tendon, we will also need to image this tendon in two planes. This is a short axis view of the patellar tendon, highlighted in green. You can see it's echogenic, as we can appreciate right here. This is a short axis view of the patellar tendon again in video format. Lastly, we'll focus our attention on something referred to as the femoral trochlea view. This view involves repositioning the patient. You will need to have them fully flex their knee, as you can see in the photograph here. This is a great view to assess the trochlear cartilage of the femoral condyles. To obtain this view, we will place a transducer transverse across the joint, just like so, angling our ultrasound probe inferiorly deep into the joint itself. In doing so, you'll pay particular attention to these hyperechoic line here, which is the cortex of the femoral condyles, and this anechoic stripe here, which represents the hyaline cartilage of the articular surface. Note how relatively uniform the space and the echogenicity is in this normal knee joint. And here's a video clip demonstrating that same anatomy. Again, here you can appreciate how uniform the space is throughout both the lateral and medial aspects of the joint. Now, let's go on to a few examples of cases and see how you can test your skills. So here's an example of a patient that presents to the clinic with knee pain. Here, by way of orientation, this is tibial tuberosity. Here we have patellar tendon, and we don't really see it in the field of view, but it would be inserting onto the patella right here. What's unique about this is that you have all this soft tissue swelling anterior to the patellar tendon. In general, we don't see that much soft tissue swelling in this area because this is where the bursa lie. But here, because we have all of this swelling, this anechoic fluid with this echogenic material in this enclosed space, this is consistent with an infrapatellar bursitis. Again, normally the bursa are not well seen in the normal condition. Okay, so here's a patient that presents to clinic that has many months of knee pain of their right knee without any history of trauma. No fevers, normal vital signs. So you place the ultrasound after doing a physical exam. And here, as you look along the lateral aspect of the knee, you get that nice trochlear view with that uniform anechoic signal of that portion of the joint. However, as we move and look towards the medial aspect of the joint, here we can see an obliteration of that anechoic space and increased echogenicity along the joint line. And these findings are consistent with severe osteoarthritis. Last case. This is a case of a patient that tripped and fell while running, landing directly onto their knee. And when they present to your clinic, they're unable to actively extend their knee and have extensive pain and swelling about the knee. Now, by way of orientation again, here we have patella, and here we have patellar tendon. And as you can see, the patellar tendon is no longer attached to the patella as it should be. And as you can see, here's patella, here is the patellar tendon, and here you can see where it's no longer contiguous and no longer attached. This is consistent with a patellar tendon tear. So in closing, hopefully over the course of this presentation, you now have a better understanding of why ultrasound in many ways can be an ideal modality for many musculoskeletal applications. We talked about how you can use musculoskeletal ultrasound to identify peripheral nerves, to identify the flexor and extensor mechanisms of the digits using a water bath, as well as how we can assess the many different aspects of the knee. Just remember, when you perform musculoskeletal ultrasound, you need to make sure that you use the appropriate equipment. Namely, you want to make sure you use a high-frequency transducer because much of the musculoskeletal ultrasound anatomy is very superficial, and this will afford you the best image quality. Remember also this concept of anisotropy, and that patient position and probe positioning can very much be used in your favor to help mitigate this difficult physical property. Lastly, recall that you can use a water bath, or sometimes something called a standoff pad, to help visualize structures that are very superficial. In doing so, you can greatly enhance your image quality. Here are some references used for our presentation. And we'd like to thank you very much for your attention. Now we're looking forward to going on to the next step of this module, which is to scan with each other and learn some additional musculoskeletal ultrasound. Thank you.